Good morning, good afternoon, good evening, students. Welcome to FTLM, also known as For the Love of Medicine. So, for those of you who thought that was the name of the course, when I go back and check the syllabus, it actually stands for something else. So, check the syllabus, guys. All right, so what is FTLM? It is a metacognitive exercise. It's a supplemental course, longitudinal small group exercises where you are thinking how to think. We are using two different things here throughout the year. One is the ecological approach, which is a cognitive strategy to solve clinical problems. And the second thing is mind maps, which are scaffolding tools to retrieve information. So we will be using our mind maps as a vehicle to drive on a road, which is the ecological approach to arrive at the diagnosis. For those of you who are familiar with the 20 question guessing game, this will feel like a highly sophisticated version of the 20 question game. So where you basically use a strategy to arrive at the diagnosis in an efficient manner. And a little bit more on it later. So what are mind maps? Mind maps are basically mental closets where things are organized. So you can see here, this person has a closet where everything is neat and organized. And of course, it will be easy to get items from here and get ready fast and be on time. However, here is another closet down here where things are very disorganized, and obviously it will be difficult to retrieve items from this closet. We will be asking you to create mind maps, and we will be providing you mind maps every week for the patient presentation at hand. Now, mind maps can be any format. They can be spider web, they can be flow charts, they can be simple charts, they can be in the form of lists, boxes, or paragraphs, or whatever you like. But the bottom line is that they should be such that you have your knowledge organized. So you'll be creating, I'll be providing you mind maps for each patient presentation every week, and you'll be creating a mind map on the board in the small group at the time when you are doing the FTLM. So here is a quick example of pathophysiologic mechanism mind map for hypertension, which you just went through. You can see here, this is just an example. So this is just showing how essential hypertension has influence on so many different mechanisms. And we also know that essential hypertension is the most common cause of hypertension. And then, of course, there are other categories that can cause hypertension. But this is not a part of the FTLM. This is just an example. Here is the clinically oriented hypertension mind map, where you are looking at the mind map itself. There are in the black font, you have different categories which are based upon the mechanisms which can cause hypertension. So you can see 90% of the time essential hypertension is the case, and then of course you have renovascular, endocrine, sleep apnea, and the others. And then in the blue font, you have diseases which are basically happening because of these mechanisms, and these diseases will need to be memorized by you when you are solving cases, because if you don't know the name of the disease, you will never arrive at the diagnosis. And then in the green font, you can see that there are risk factors, patients' symptoms and signs, historical features, and then of course you will add some physical features, physical exam features as well, which are not here on this mind map, but those will need to be included as well. And finally, in the purple font, you have diagnostics, which are usually going to be your labs and your imaging and all the confirmatory tests. So you can see that once you have started to see a patient with a patient presentation or with a problem, you will not necessarily jump to the final stage of ordering tests and labs to arrive at the diagnosis. You will first organize your information, try to ask all the right questions, and then finally order tests appropriately. In the left upper hand corner, you have a box where it is showing a couple of other things that we will be talking about as we go through this presentation. So in order to use this mind map that we have here, we will be using this cognitive strategy, which is Ecological Approach. So Ecological Approach is a TCOM invented cognitive strategy. It is a strategy. It is not the only strategy. You can use any other strategy as long as it makes you efficient, accurate, and logical. but for the purpose of this course we are using this because we're thinking that this will help us. These are the 4 steps of this approach. So whenever you are seeing a patient, there are 4 steps that you go through, and I'll talk about these 4 in detail here in a second. But basically these are building probable diagnosis for the problem or for the patient presentation or chief complaint, then checking urgent and emergent situations, weighing all the information, and removing anchor bias. So what is the step number 1? Step number 1 is building probable diagnosis or differential diagnosis. So these are basically by the chief complaint or the patient problem. It can be a symptom that patient is complaining about. It can be a sign. For example, in this case, it's elevated blood pressure, which is a physical exam finding. It can also be a lab finding. So it can be anything that is presented to you. And based upon your knowledge, which you have acquired already, you will be listing differential diagnosis. You don't necessarily have to list them on a paper as such, but as long as you have them in your head, that is enough. It is better, always better, to list the differentials based upon how common or less common they are, so based upon epidemiology. So for example, for hypertension, you don't want to list pheochromocytoma as the top differential. You want to do essential hypertension as the top differential, because believe it or not, juvenile detention occurs in juvenile 100% of the time. So also always look in the box of what your knowledge base is before thinking outside of it. So that is a step 1. If you don't have step 1, or if you are not able to think about all the differentials, you are not going to obviously arrive at the correct diagnosis necessarily. Studies show that people misdiagnose the most when they don't think about a certain diagnosis. So step number 2 would be that you will look at the patient and make sure that there is no urgent or emergent situation. Urgent and emergent situations are basically life-threatening situations which are usually presented, or which are usually assessed based upon a patient's vital signs or patient's appearance. So for example, blood pressure, heart rate, temperature, oxygen saturation, respiratory rate, and just the overall general appearance of the patient. This data needs to be gathered or examined before we proceed further, because sometimes you will need to intervene before you finish evaluation, because believe it or not, we would like to have our patients alive in order to finish our evaluation. Step number 3 would be weighing. So this is where your game of 20 questions comes into play. Weighing is basically gathering information, gathering patient's history, looking at the past medical history, gathering physical exam findings, and asking the high yield questions and then the medium yield questions to arrive at the diagnosis accurately and efficiently. So what are high yield questions? So the high yield question would be one that you ask, and after you get the answer, you can basically divide your differentials into 2 or 3 broad categories. So it is not a very highly specific question. So for example, here you are playing this game of 20 questions and you are asking if the object is living or non-living, and if the person playing with you says that this is a non-living object, you don't want to start asking questions about birds and elephants and humans necessarily. You want to probably ask questions about is this thing made of wood, or this thing made of whatever material, so you are in a different category. So therefore you can see that asking this question about whether the object is living or not becomes a high yield question, because it's giving you a direction to go this way. Now, after you've determined that your patient belongs in one category, after you've asked the high yield question, you can then ask more focused follow-up questions. And the focused follow-up question in this case, if you've decided that this is a door or a non-living object, you can ask about the material, what it is made of, or the general size or whatever. So those are the focused follow-up questions, or the medium yield questions. So remember the differentiation between high yield and medium yield questions. The world is not going to fall apart, and it's not going to come to an end if you ask medium yield questions before the high yield questions, but it will just make you more efficient if you are doing it the right way. So in the case of hypertension, if you're evaluating a patient for hypertension, you already know that most of the patients are going to have essential hypertension. So it's always a good idea to look at the age of the patient first. So age of the patient in this case becomes the high yield information or high yield question. or piece of data that you're gathering. Instead, if you start asking, or does the patient have palpitations, because you're thinking about pheochromocytoma, and palpitations is a very specific feature for pheochromocytoma, it will not really help you too much. You will be basically wasting your time. So that is the purpose. This is the purpose of using high yield questions for weighing purposes. And after you've gathered enough data and you've enough information about one diagnosis, and of course you pursue that diagnosis. So let's move on to the next step. So after you've gathered enough information about one or two stop working diagnoses, then you want to make sure that you remove anchor bias, which basically means you don't arrive at the diagnosis prematurely, or don't prematurely close your encounter. So you check at least one major feature for the less likely diagnosis as well. For example, if you're seeing a patient who has hypertension and it's a female patient, and you already know that she started taking oral contraceptives and that's when the blood pressure started to go up, you already have enough data to make a conclusion that probably it's medication-induced hypertension or hormone-induced hypertension. At this point, you don't want to close the encounter. You also want to ask a couple other questions about each of the major other differentials. For example, you want to ask about the most common symptom of hypothyroidism, which is fatigue. So you want to ask about fatigue. You also want to ask about the most common symptoms of other things. For example, if she's taking any other medications, or if she's has a family history of hypertension and stuff like that, or if she has a history of kidney disease, or history of recurrent kidney infections, which can put her at risk for renovascular hypertension. So those are the things that will basically make sure that you are touching all your bases and you are not leaving anything ignored. And this will help you reduce errors. So that is removing anchor bias, but you don't want to just keep going down and down in a rabbit hole, removing your anchor bias and just ask every kind of highly specific question. This is just for journal more prominent features of diseases. So after you remove the anchor bias, you then of course do the physical exam and then appropriately order labs and tests and then arrive at the diagnosis. So here is the ecological approach in one slide. So here we start with the patient presentation X, and it can be, this approach, as you can see, can be applied to any patient presentation. It can be a patient's chief complaint, it can be a physical exam finding, or even a lab finding, as long as you have a mind map or knowledge base organized in such a fashion that you can retrieve information quite easily. So based upon the presentation X, you build a list of probable diagnosis or differential diagnosis, and then you say, okay, well, I think A, B, C, D, E are more, and R1 are more likely, and you are listing them because of epidemiology. And I understand that at this level you do not have much epidemiological data, but as you advance in your training, you will have more and more information about it, and you'll become more efficient in this. And then you also want to say, okay, well, I know that F, G, and H are also possible. They are less probable or less likely, but they are possible. And then R2 is another diagnosis that is possible. After listing this, and or after quickly thinking about all these differential diagnoses or probable diagnosis, you will check for urgent and emergent situations. So you will quickly look at the vital signs and the patient appearance, and if any of that suggests that patient is suffering from a situation which is immediately or imminently life-threatening, then you will basically intervene, and you will gather physical exam findings appropriately and quickly, and then of course perform diagnostic tests and intervene. However, most of the time, luckily, this is not going to be the case, because most patients are not in a life-threatening situation. Most of the time, patient is going to be relatively stable. So we are hoping that most of the time, unless you are an ER doc and you happen to be on a bad shift, these things are going to be negative. So if they're negative, then you can start asking high yield questions, and this is where you are doing the weighing. So this is your step number 3. You will ask high yield questions about the more common diagnosis, and let's say the answer suggests that A, B, and C are likely because you have positive feature, one positive finding that is common to all these 3 diagnoses. Now you will start asking focus follow-up or medium yield questions about A, B, and C individually. And let's say at the end of that questioning session, you have 4 positive symptoms for a diagnosis A, 2 for B, and 1 for C. You decide that, okay, maybe diagnosis A is more likely. So at this point, that is your working diagnosis. But then you will say, okay, wait a minute, I'm not going to stop here because I don't want to be in a situation where I have adopted to cognitive ease. I want to make sure that I remove anchor bias as well. So in order to remove anchor bias, you will ask at least one major question for FGH also, because you want to make sure that the patient, you're not missing anything. Let's say that those answers are negative and patient doesn't have any of those big symptoms or features of these unlikely diseases, then you will go ahead and say that A is probably the most likely diagnosis. I'm going to go ahead and do the physical exam and then perform diagnostic tests and finally arrive at the diagnosis. Let's say, on the other hand, that there are some very strikingly positive features present for FG and H, or one of these. Then at that point, you'll say, okay, I'm going to gather now more data. So you go back to step number 3 and then start all over again from this step, and then keep going until you have enough information. And at the end, of course, you will weigh all your information and then arrive at the diagnosis. At times, you will probably need to perform more than one diagnostic confirmatory tests to make sure that you have the correct diagnosis, because patients are not always going to present with typical features. Patients never read the textbook. I can guarantee you that. But then also, stronger the knowledge base that you have and better your mind map or mental organization of the information that you have, more likely it is going to be for you to arrive at the diagnosis accurately, logically, and efficiently. So that is the ecological approach. We will be using this throughout the year. I hope you will enjoy it. I hope you will learn a lot from it. If you have any questions, of course, feel free to email me, stop me in the hallway, or just call me, anything. And in the end, like I said earlier, this is an approach. It is not the approach. And there are many other ways you can use a cognitive strategy to arrive at the diagnosis, as long as every road that you adapt leads to Rome. So thank you so much. Now you can go ahead and start with your FTLM session. Thank you.